relapse involves new or worsening neurologic symptoms that is lasting greater than or equal to 24 hours. And it also occurs greater than or equal to 30 days after a prior relapse. And it is not explained by infection, fever, or metabolic disturbances. And then the first line treatment for multiple sclerosis relapse is high-dose corticosteroids. So, IV methylprednisolone is one example of this. It is a high-dose corticosteroids, and the dosage can be between 500 to 1,000 milligrams intravenously every day for about 3 to 5 days. Alternatively, an oral effects include flu-like symptoms, injection site reactions, elevated liver enzymes, and depression. You can monitor for the drug response and for any side effects by checking the complete blood count panel and the liver function test, especially since this particular therapy can elevate the liver enzymes. We also have glatiramer acetate. And so the way this works is it mimics the myelin basic protein, and it also induces the regulatory T cells. Now, some adverse effects to watch out for include injection site reactions, and then transient chest tightness and flushing, although this may be benign. And then some advantages to the glatiramer acetate, in contrast to the interferon beta, is that there's no routine lab monitoring required, and it is safe to use during pregnancy, although this can be relative in general. Then we have oral therapies like fingolimod. So, fingolimod is an S1P receptor modulator. What ends up happening is that it traps the lymphocytes in the lymph nodes, thereby preventing the lymphocytes from entering the central nervous system. And then some adverse effects to watch out for include bradycardia, especially with first dose, macular edema, lymphopenia, and herpes infections. And for monitoring, you must do first dose cardiac monitoring due to the bradycardia. Also do an eye exam due to the macular edema and a CBC. We also have dimethylfumarate, and the way this drug works is that it will activate the NRF2 pathway, and the activation of this pathway, the NRF2 pathway, has some anti-inflammatory and neuroprotective effects. On the other hand, the adverse effects include flushing, GI upset, lymphopenia, and very rarely some progressive multifocal leukoencephalopathy. So, that's something to remember for dimethylfumarate. We also have teriflunomide. So the teriflunomide will inhibit the pyrimidine synthesis. This is going to lead to a reduction in T cell proliferation. My goodness, I cannot pronounce words today. Anyways, the T cell production is reduced because of the inhibition of pyrimidine synthesis, and that's what makes teriflunomide special or interesting. Just remember that teriflunomide starts with the letter T, so it's going to affect T cells. Now for adverse effects, watch out for hepatotoxicity, alopecia, or balding of the hair, and then peripheral neuropathy. And then, this is very important, it is contraindicated in pregnancy because teriflunomide is teratogenic. So, once again, teriflunomide starts with the letter T. T can remind you of T cell proliferation being reduced, and that T is also teratogenic. Okay, now let's move on to some monoclonal antibodies that are out there, and they serve as high-efficacy disease-modifying therapies. First, we have natalizumab, which is an anti-alpha-4 integrin. The way this works is that the natalizumab is going to prevent leukocyte migration across the blood-brain barrier. So some major risk to watch out for is the PML, and so associated with alemtuzumab is autoimmune thyroid disease, ITP, I think immune thrombocytopenic purpura, and then infections and malignancy risk. And then for use, alemtuzumab is useful for highly active multiple sclerosis that happens to be refractory to other therapies that we mentioned earlier. So remember, monoclonal antibodies include natalizumab, which is an anti-alpha-4 integrin, ocrelizumab, which is an anti-CD20 antibody, and alemtuzumab, which is an anti-CD52 antibody. And then for your oral therapies, they can include fingolimod, which is an S1P receptor modulator, dimethyl fumarate, and teriflunomide. And then your disease-modifying therapies, we talked about earlier, interferon beta and glatiramer acetate. So, let's talk about some progressive forms of multiple sclerosis and how we treat them. So, for secondary progressive multiple sclerosis, if there is active inflammation, you can treat it similarly to how you would treat the relapsing remitting multiple sclerosis. And remember that for the RRMS, or relapsing remitting multiple sclerosis, you would use corticosteroids or plasma exchange if the symptoms relapse even after using steroids. Okay, and then another medication called siponimod is approved for active secondary progressive multiple sclerosis. And then for primary progressive multiple sclerosis, remember that we mentioned that ocrelizumab is the only proven disease-modifying therapy, and it has modest slowing of disability progression. So remember that ocrelizumab is an anti-CD20 antibody, so it depletes B cells. And then for symptoms